the NSI Bangalore chapter. This is the last webinar of this series, and we are very fortunate today. We have amongst us Dr. Himanshu Mohan Kumar, the International Health Researcher and Physician, Deputy Medical Director and National Epidemiologist from Doctors Without Borders, New Delhi. We welcome you, sir. We welcome Dr. Our Lakshmaya sir also, the Secretary, National Secretary of NSI chapter from Hyderabad, and all the members who are present here with us, the students, the researchers, and also the dietitians who are here with us for this webinar. And we all know that the current interest of many of us is with our pandemic, which is amongst us for so many days. Hope it's slowly leaving us and moving away from us. But today, we will know more about it from Dr. Himanshu Mohan Kumar. So to introduce sir, I request our treasurer, Ms. Lakshmi Jitendran, to do the honors. Over to Lakshmi. Once again, I welcome you all.
Thank you, ma'am. Good afternoon, everyone. It's my pleasure to introduce the speaker for the day, Dr. Himanshu Mohan Kumar. He is an international health researcher and physician by qualification. Professionally, he is into MSF, an international medical humanitarian organization, since 2017. It's a worldwide organization which provides emergency medical care to the people who affected the conflict, epidemics, and natural disasters. Dr. Himanshu plans and manages operational research, epidemiology, and clinical services of MSF in Kashmir, Manipur, Chhattisgarh, and New Delhi. Recently, Dr. managed MSF's COVID-19 epidemic interventions in New Delhi and Manipur, where field ICUs and emergency mobile teams treated COVID-19. His areas of interest include quantitative research, epidemiology, design, monitoring, and evaluation of health interventions. Himanshu has led several major research projects related to design and delivery of healthcare in areas of sexual and gender-based violence, HIV, hepatitis C, mental health, and malnutrition, which is funded by several international agencies, including the UNITAID of WHO. He has published several research papers in international journals and presented various papers in international medical conferences which held in London, Amsterdam, and Tehran. Key publications include Inequality Modeling of Maternal Health Services, Integrated Treatment of HIV and Hepatitis C in Vulnerable Population, and Improving Access to Medical Services for the survivors of sexual and gender-based violence. Himanshu has a 10-year experience in providing the medical care in humanitarian situations like floods, epidemics, and conflicts. He is involved in design and delivery of long-term medical programs in primary healthcare sector, maternal health, malaria, malnutrition, HIV, TB, hepatitis C, substance abuse, and mental health in chronic humanitarian contexts. Owing to experience in medical research and organizing medical care for the marginalized populations, several medical organizations, including Government of India and WHO, have included Sir in several technical committees and working groups. Prior to his engagement with MSF, Himanshu was the medical academia, where he started his career as an assistant professor at Department of Public Health, Rajiv Gandhi University of Health Science, Bangalore. Himanshu sought professional and postgraduate education from MS Ramaya Medical College, Bangalore, and Uppsala University in Sweden. With this kind introduction, I welcome you to take over, sir. Thank you. You can share the slides, sir.
Yeah. Thank you, Dr. Lakshmi, and thank you everybody, all the office bearers of NSI and the participants, for inviting me to this webinar. It's been a while since I've actually worked in nutrition, although we have some malnutrition projects, but they are quite simple and straightforward. And my first, I used to work in malnutrition at least 10 years ago. And it was with this engagement that I came in contact with NIPSID and Dr. Jyoti, where we used to train some Anganwadi and Asha workers. However, when I was asked for this webinar, I was told that they are not looking for anything with nutrition, but a little more on the pandemic and something beyond the basics. So at that point, we came up with this idea of talking about post-COVID health system scenarios in India or abroad. I must admit this was sometime in July, and at that time we were running through the peak of second wave in different parts of the country, and my mind at that time was largely thinking on lines of what would happen to our health systems after this pandemic ended. However, I'm not sure if this was the right topic going ahead because things have changed in July and a lot of there are many other important discussions which are around. So, keeping this in mind, I have kept this discussion quite broad, and and I'm open to discuss anything else that any one of the participants or the office bearers would want me to stress upon, which is within my knowledge or expertise. So, if the presentation or whatever I'm going to talk, it does not is not going to be as threatening as the topic suggests to be. So we try to keep it as simple as possible. At any point in time, if you feel or any one of you feel that I'm talking quite fast or difficult to understand, kindly raise your hand and interrupt me. And if there are any audio or technical issues, please feel to interrupt me. But I was told that there is another question and answers or a discussion time, so we can keep the discussions for a later time. I would just now attempt to share my screen. Right. Can anybody please confirm if this is visible?
Yes, yes, sir. It's visible.
Okay. Am I audible also?
Yes.
Is my voice enough?
Yeah. Yes, sir.
Should I
Perfect.
speak louder?
Yeah. Thank you.
Okay. Thank you. So there has been a brief introduction of myself, and I'm a relatively a new person in the area of international and public health, where we try to program medical, where we try to program models of care to deliver the best health possible in very challenging situations. So with this, pandemics are something which we or our specialty handles, and we have been into this, into modeling and actually intervening in pandemic across the country since the beginning of the first wave. So whatever I'm going to speak to you now comes out of some amount of published research, well-established facts, and at some points comes out of some experience which we have gained in the field in the past 2 years. There may be a few things which are just my opinions, and I would warn you on that, that these may not be hard facts, but it will be only my projections or opinions. So basically today we are going to talk about what would be or what our health systems may look like after the pandemic ends or during the rest of the course of the pandemic. So to understand that, it is essential that we understand some basics of what this pandemic looks like and how it is affecting us and how this would shape our future health systems. Of course, there's a lot to talk about COVID and SARS. There are just too many angles to it, aspects to it, determinants to it. But I will only stress upon what is more relevant to today's discussion. And since we have lived through 2 years through this pandemic, all of us are quite aware of the basics, and also some of us may still have some advanced knowledge, and maybe some of us have experienced suffering this disease as well. Anyway, this whole pandemic is driven by a virus which is now designated as a SARS-CoV-2. The name hasn't changed since its discovery, and this belongs to a group of corona RNA viruses, which are not new to humans, but this variant of COVID-2 is something new. This coronaviruses generally are known to cause common colds in humans and many animals. There have been two previous outbreaks of of different strains of coronavirus. Recently, one being SARS in 2002-3, which started in Asia, and then there was another outbreak in 2012 called MERS, Middle Eastern Respiratory Syndrome, which started in 2012 and is still endemic or existing in some levels in the Middle East, largely in Saudi Arabia and the other countries around it. So this particular SARS-CoV-2 is transmitted through, just like any other flu virus, that is through air droplets. There have been rumors that it could still spread without a droplet, just in plain air, but these reports have not been confirmed. And at this moment, we continue to believe strongly that this virus spreads through the humidity factor present in air. But COVID-19, which is the disease that is caused by SARS-CoV-2, is an emerging viral disease, and it's a new strain. So that makes the entire humanity or population in the world susceptible because they are not immune to this particular variant. So, why does it spread, or how does the spread or transmissibility compare to other diseases? The MERS, which is also a coronavirus, spreads only to 0.7%. That means it takes uh, constant contact with two people for one of them to get this disease from an infected person. We also have another ongoing epidemic in parts of Africa called as Ebola, which started in 2012. That spreads to one person can spread to 1.7. That it requires more than 4 people for at least 2 people to be affected. Then we've had this old epidemic called smallpox, which is no more, which is eradicated. It's one person could spread it to 7. And we still have this disease called measles, where one person can spread to 17 different people. So these are some of the epidemics where there are ongoing, and these are the transmissibility factors, which we commonly known as the R factor. So where does COVID or SARS-CoV-2 stand? It stands at something between 2 and 3. So one person can spread to 3 other people, 2 to 3 people, which means that it is more transmissible by MERS and Ebola and less transmissible than smallpox and measles. Before I go to this, sorry. But what makes SARS-CoV-2 such a big issue or a pandemic, while MERS, Ebola, smallpox, and measles doesn't? Smallpox, of course, was a major issue long ago, and it's completely eradicated, so we have no experience with it. While the problem with COVID-2 is that it spreads through air droplets, while Ebola spreads through fluids, and MERS spreads through very dense air droplets, and measles spreads through air. But with SARS-CoV-2, another problem is that none of the humans have previous exposure to this variant of coronavirus. So that makes everybody susceptible. While that may not be the case with measles, as most of us would be vaccinated with the measles vaccine. So the susceptibility factor is quite low. So that makes coronavirus or the SARS-CoV-2 virus more spreadable than others. So another issue is that today in 2021, we are more globalized than we were. The human-to-human interaction is the most at this point in time than ever in human history. So that allows for the COVID virus or the coronavirus to spread between countries or between states, between districts, between villages very rapidly. Unlike any of the previous epidemics that we have experienced. And therefore, we have put ourselves today in this situation. So what does this SARS-CoV-2 virus cause? It causes a disease, a spectrum of diseases, mainly related to the respiratory system. And I must promise you that the disease it causes is in no way as severe as any of the four other diseases which we discussed earlier, be it MERS, measles, smallpox, or even Ebola. So this particular virus causes a disease called COVID, coronavirus infectious disease, and it could cause a wide range of clinical presentations, right from being an asymptomatic infection. If you were to see the pyramid, most of them are just infected without any symptoms. For some people, but then there are a small proportion of population, maybe about 20% of people who are infected, show some symptoms, and that's usually an upper respiratory tract infection. However, about 10% of the people, of all infected people, are not lucky. They tend to develop some kind of pneumonia, and 5% of them end up in hospitals. So they would require some antibiotic coverage and oxygen and anticoagulation and some amount of basic hospital support. A very small proportion of them, about 1%, get into the ICU because their lungs get severely damaged by the virus. And they may develop into a syndrome called a systemic coagulopathy. And half of the people who get into the ICU usually don't survive, and that leads to death. So this is the current situation, or this is the clinical syndrome, clinical picture that we have of COVID virus. This remains the same from what it was in March 2020 till today. That means that the virus has not evolved to infect any other organs or cause any different clinical syndromes, thankfully. So I'll come back to these clinical characteristics and spread, but now let's try to just understand what the outbreak means to the human world, which may affect our health systems. So the key features of this outbreak has been that this disease has affected over 223 countries. This picture shows the shades of different, the picture shows the territories which have been affected by COVID. And the different shades of blue are the extent to which there have been confirmed cases. But you see on the global map that there is no non-blue area, which means that it is truly a pandemic. This was not the case a year ago, but now there is just no territory which is not affected by COVID. And this is largely because of two factors. One is the novelty of the virus, that humans do not have immunity to this and everybody is susceptible. And the second factor is that we are more globalized, or the most globalized than ever in human history. And therefore the virus travels with humans all over the place. How does it look in India? As on date, this is of 31st October, that's 2 days ago, we know that every part of India, mainly the districts, have a confirmed case of COVID. So this map shows you the confirmed number of cases per 100,000. And but in India, we know that the cases are significantly more in urban areas than in rural areas. Furthermore, we know that this particular disease has spread rapidly across populations, but the outbreaks have occurred in waves. Yeah, I'm sorry for the clumsy picture which is here, but this is the time trend of new cases that have been reported worldwide, and we see across the globe there have been 3 peaks. Now, these waves occur due to the social response that we provide to the virus and because of the new variants. Meaning, once there is an increase in case in any area, immediately we put a lockdown or we have movement restrictions. And we take certain measures. The wave peaks and recedes because human communications and human interactions decrease. So hence the wave recedes. Then over a period of time, the virus is reintroduced into the population. And this time can also lead to generation of a new variant, which can lead, or which has often led to another wave. So by going by theoretical knowledge of epidemics, we understand that the intensity of initial waves are unpredictable. The first wave can be dangerous, the second wave can be dangerous, or the subsequent wave can be very dangerous. Difficult to predict the pattern. But however, we are quite sure that the intensity of successive waves after the pandemic settles decreases over a period of time. That is because most of humans would have developed immunity to this disease, or either through being infected or through vaccinations, and the chance of the virus, the probability of virus mutating decreases over a period of time. So the intensity usually at some point in time will decrease. So, well, how did these waves occur in India? In India, however, we have seen only two waves. Of course, India is a very big country for us to categorize, but speaking as a unit, we see two waves. But there have been some cities like Delhi, which has experienced three waves. Apart from Delhi, I think the other one was Kolkata and Imphal and Mizoram. A few states have had three waves. But in the beginning of the pandemic, we did predict, our organization did predict the number of waves that would happen from March 20 to November 2021. So that is the first left graph. Um, so we should have had another ongoing wave now, but this did not happen. What happened to us was what we see in the right. Now, there are many reasons why this happened. One, because of the national lockdown that we have, and also the patterns of lockdowns and the patterns of responses which we provided, and also that we did not know much about the virus previously and due to several biological differences. Anyway, that we may not get into the debate of why this happened, but we still see that we have had the second wave. And there are talks of subsequent waves occurring in India, timing of which and the intensity of which is still unknown. So, if this is the extent of spread, why is it a big deal? What? So what? What happens if it comes in waves? What happens if it spreads all over the world? The point is that people die. The theoretical case fatality of any such virus should be about 0.1 to 0.5%, depending upon the age and comorbidities. This is how other coronaviruses have behaved. Meaning, you would require 1,000 infected people to witness even one death. But that has not been the case in practice. What has happened due to this widespread of this pandemic is that there have been 1 to 3% of case fatality rate. This is what is recorded. It can still be higher. I would project it about 5 to 6%. Now, why does this happen? Is because we have a sudden waves of cases, right? A lot of cases occurring at one point, and that saturates our health systems. People do not have beds. There is no availability of timely medical help. Everything goes into a shortage when there are just too many people queuing in front of hospitals, and many people who could otherwise be survived end up dying. So most deaths that occurred in India and in the world, including the United States, due to this were preventable deaths. Would meaning that if the health system could have accommodated them, perhaps many would have survived. But however, this particular pandemic or the intensity of this outbreak has been such that it has saturated every health system in the world. And this is something which we'll have to live with until this virus remains with us. So, if I were to summarize the key concerns of COVID in relation to our organization of our health system, it would be that this spreads rapidly due to the novelty, and that is still a reality. There's a lack of specific immune response in humans, so it would remain in this pattern unless we have enough immunity to counter this virus. There is saturation of health systems during the wave. Maybe the wave can be small, big, it could be localized, it could be in a district, it could be in a village, it could be in a city. And then these things have to be seen in the view context of a disintegrated and weak health systems, which often cannot accommodate this size of the burden. And when these waves occur or these outbreaks occur in rural areas, our primary and secondary healthcare systems are not capable of handling COVID. They're not meant for this at all. They're meant for a very different purpose. And in India, we have also faced this double burden of comorbidities. We have malnutrition, enormous degree of malnutrition. And we know that pneumonia is not well cured in people who are malnourished. And malnutrition and pneumonia has a very traditional strong linkage leading to mortality. On the other hand, we have significant proportion of people suffering lifestyle diseases like coronary vascular disease or diabetes, which also does not help in healing of pneumonia and render mortality risk to such people. So therefore, we do have a significant problem on hand, and by considering the fact that much of this mortality is preventable. Now, before we analyze what it does to our health systems, there are a few uncertainties of COVID today which we need to factor in. One is that vaccine effectiveness is slightly under question, meaning that we do not have any vaccine that is 100% effective. There's a difference between efficacy and effectiveness, which probably is not for today. But effectiveness is largely understood as when you provide vaccines to a large population, to what extent it can prevent disease is what is the measure of effectiveness. All vaccines that we have today is reasonably effective or to prevent hospitalization and death, but they're not very effective. That means at least to 30 to 35% inefficiency in preventing an infection. So I must say that we do not have the best of the vaccines yet, and it's acceptable that we are still only 2 years into this research. Then we do not know how long the immunity that is provided by vaccine lasts. These are all just projections. We have to live through that period in reality to know what has happened, to whatever extent it remains with us. Likewise, we're also not aware the period of natural immunity, which means that people who have been infected by COVID also have generated some immunity within themselves. We're not aware, or we do not know how long this lasts. But looking at other viruses before, I hope, or rather it is hoped, that this immunity lasts a lifetime, but that may not be the case with period of vaccine-induced immunity. And then we're not sure whether the mutations, how many more mutations come, and how many more variants come, and what these variants would mean, or how deadly would they look. So with all these, we still continue to live with these uncertainties, and hence a threat of an outbreak, even though small, will remain in the foreseeable future. And all this means that we adapt our way of life and we adapt our health systems accordingly, considering these challenges and considering the uncertainties in such a way that we can prevent mortality. So adapting existing health systems at a in a post-COVID scenario would mean two things. The health systems should be able to prevent an outbreak within the health system or around it, and then we should be able to contain and handle an outbreak. Now, health systems has many health structures, like the primary health structure to the community health centers, district hospitals, subdivisional hospitals, private hospitals, tertiary care, secondary care, and so on. None of these health structure is out of risk of an outbreak. Rather, in a community, a health structure can become a point of an outbreak because there is a natural gathering and crowding of susceptible people and sick people at these health structures, be it a PHC or a tertiary healthcare center. So these health systems or hospitals remain as a high-risk center for an outbreak. And therefore, in the last two big waves, we saw that the health systems were locked down or repurposed only for the purpose of COVID. Even introduction of one COVID case can lead to a small outbreak in a rural area. And we are all well aware that the most utilized crowded health system space is a primary health center in a rural place. And any such outbreak in a primary health center would mean an immediate outbreak in a rural area. It may not lead to a big national wave, but it can still cause significant mortality within those small spaces. Secondly, our health system should be able to contain and handle an outbreak if it occurs. So what they should be capable of is they should be able to suspend their other healthcare service immediately, lock down, but at the same time reorganize their healthcare services, because you cannot keep other patients waiting or out of service for a long time. And then these systems should also provide treatment to the diagnosed COVID cases and contain an outbreak in the community. So, before we adapt or talk about what is the post-COVID adaptation that is required, we can now see which health components, sorry, health structures are more at risk for such an outbreak. The highest risk of health structures, these are largely our projection, is the primary health centers because people crowd for there for various different diseases, simple diseases, and they're also nodal points for nodal centers for all the national programs, and they have a strong outreach component. Some of the PHCs are now 24 bar 7. They have they have delivery services, maternal and child health services, and and they have a continuous footfall. In Karnataka, an average OPD presence as for simple diseases in PHC is about 150 to 200 people per day. This may be 3 or 4 times more in northern India. And the community health centers, I got an opportunity to visit a few during lockdown and even recently in central India. And these are quite risky places too because recently the government has upgraded many PHs into community health centers, which provide more advanced maternal and child health services. So these are places where they have a PICU where cesarean sections happen, some deliveries, good amount of deliveries happen, and they are also frequented by people with slightly different accidents, wounds. They are developed as a secondary health center. So the amount of people and the kind of people, susceptible people, come to these places is a bit worrisome. And then we have this severe acute malnutrition rehabilitation centers. So here you have a bunch of children with their mothers who stay, uh, who are just coming out of an active treatment for SAM, and they have this rehabilitation phase. That is when they're very susceptible to pneumonia or disease. And these centers are often crowded because there is a child, there is a caretaker, there are many other workers, and there is somebody serving food, and there are people running in and out. And we see that these SAM rehabilitation centers are not very strategically placed because, of course, it cannot be placed well deep within a hospital because there are other risks of other infections. So they're placed somewhere between a health center and the community, so which provides a reasonable risk to both children and mothers in these centers. And the routine immunization centers, because we run routine immunizations in most of PSCs and CHCs on particular days, 2 days a week, where there's large crowding or gathering of children and mothers and caretakers. So these are also high risk structures. The medium risk structures are the tertiary and secondary hospitals, the big hospitals. They're not much under risk is because they're largely spaced. They have different departments. They have the patients go to very different sections, and there's hardly any chance of crowding. So the whole availability of space makes it less riskier than primary health centers. And of course, private clinics and nursing homes, they're very small structures. They can regulate people. They treat people for a fee or an enormous amount of money. So they're able to regulate how people come, who comes, where they go, and such. And there's some of these low risk structures, something like sub-centers. The sub-centers of PHCs, there's hardly any crowding, and the people come there for very specific reasons. So I do see it as a low risk structure. The Anganwadis too. And because Anganwadis are frequented largely by women and children under less risk for COVID. So there may not be many external agents who can bring in and create a outbreak within these centers. And any of these mobile clinics or outreach activities, even immunization is done in outreach in some places, where there is a very minimal number of people interacting at one point in time. So I do see this as a very low risk for creating any outbreak. Anyway, so what do we do? What do we do to adapt our health systems, especially the high risk uh, health structures? There are a few things which we tried, and I'm presenting you out of some experience and models which have worked. Again, I'm sorry for this very clumsy picture out here. I did not expect it to come this way in a presentation. Anyway, what it really means is that we can we can reorganize our healthcare centers to prevent an outbreak. One simple way of doing it is by introducing a respiratory triage. That would mean that every person before entering a health structure is checked for symptoms. You may see that already happening in different places, but that is insufficient. So somebody holding a thermal gun and looking at your temperature, but that's not what we're talking about. A respiratory triage would mean that there is a questionnaire administered to every incoming patient, checked for the respiratory symptoms, and then allowed in. But the person with respiratory symptoms also is allowed in, but is allowed in a very different pathway. So if you can appreciate these lines in this diagram, I'm not sure you can, but at least you could see that there is some red and blue arrows or green arrows. So these were certain pathways which we designed in an open air clinic which treated to a primary health clinic with a TB and HIV ward, a slightly complicated structure in Delhi, where we tried to differentiate where people go. And it really worked. This was when there was hardly any testing. We did this in 2020, early 2020. And now, in the second wave, this particular health structure remained functional without a COVID outbreak. So likewise, we have done similar models for reorganizing TB care, HIV care, and such, and it has really worked. So introducing a respiratory triage helps. And but it comes with a problem. It consumes a lot of space, and you need additional people, trained people to do this. Another way is to introduce testing. You can test everybody who comes in with a rapid test, but then this consumes time again and consumes a lot of money. And people are not happy to get their nose poked in every now and then. It is a painful procedure, not comfortable. And also the testing, rapid test which is available is not 100% sensitive, so you still end up missing a few things. We have tried this too and it has not worked very well. Another way is, of course, very must is to have physical distance measures within your hospitals. It's not only about two people staying at a distance of 1 meter. It is also about how you organize your patient care OPDs. Where do you want your respiratory patients to go? Where you want the people without any symptoms to go? How much distance do they maintain? What is the distance between these two rooms? Now, this again is not possible in all contexts, depends upon the amount of space available in a particular structure. But, but it is still possible to do so if you have some will and some reasonable space. And then you can limit the movement of people, which you have already been doing, where they tie ropes and ask you not to enter, but that's not the way to do it. But we can still limit movement in sense you can stagger people when they come. You do not have to mix people coming for deliveries and malnutrition or child health services with people also coming with cough, cold, and fever. So you can have separate entrances for different risk people at different risks. And this requires some amount of space reorganization. And I'm talking about all this in the context of the high risk structures which we spoke about previously. So, what are the challenges that come with this? I think I've already discussed most of them. That to do all this, you need to increase human resources for triaging and having separate treatment spaces. Then you have to have an increased expense towards your personal protection equipment like masks, gloves, and caps. And it leads to considerable space constraints in maintaining physical distance. As we discussed, this will be a luxury. And then you have this challenge in India of attenders to care for patients. In my experience, I wouldn't name some centers, but there we saw this outbreak within hospitals happening because there were no nurses to care for patients, and we had patients' own attenders, family who fed the patients, who cleaned the patients, but the COVID came through them, and that created havoc in major wards and led to an outbreak and unwanted, preventable deaths. This has happened in many parts of the country. And this remains a major challenge because this is one of the model what we follow in our country. We have tried to impress upon several agencies. We have also tried models where this where attenders entering a health system is prohibited, but it's culturally and resourcefully not acceptable. So it's a challenge we live with. And then another challenge is, we cannot limit social interactions in rehabilitation services, like that for malnutrition. We say that a child needs to play and interact with people for a to be rehabilitated from SAM. Likewise, orthopedic recovery, people with injuries, movement problems, and then mental health institutions. They're the most abandoned institutions during COVID. These cannot do without people and interactions. So, organizing care in COVID for these in these situations really remains a challenge, and we're still out of ideas. So, preventing an outbreak within health structures does require significant physical and functional reorganization, and it requires a separate set of people to work on this for a long time. So, moving ahead, we were talking about how do we prevent an outbreak, and let's talk about what it takes to handle an outbreak. Um, for a fact, lower level of health structures like primary health centers, CHCs, just cannot handle an outbreak. They are not meant for that. They're meant for very different purposes. So, what the government is planning, rightfully, is to have a common treatment center which is linked to a few of these PHCs. So, if there is a case reported, a new COVID case or a suspected COVID case is reported from any PHC or a CHC, then we are aware that an X center, which is at an X distance from this PHC, is where you send this patient. So these are what are known as COVID care centers, and now they're redesignated as a nodal COVID treatment center, where that is designated to treat COVID exclusively. So it takes the entire country to designate a particular health structure as a COVID treatment center from now on. And this activity has begun, and it will take a long time before we are able to get something effective. And then you need a rapid contact tracing, testing, and isolation response. I saw this a couple of weeks ago in a deep district in Jharkhand. There was just one case reported in a sub center. Of course, tested at a primary center. The whole district got into a tizzy. You had all the non-health actors from the taluk office and the administration, the police, trying to track down people, run with the rapid antigen tests, and try to isolate, just for one case. And this will be a reality all across for times to come. You need people other than your medical teams to be ready to trace and test the community and isolate people immediately. So you need a response team prepared at the district level or even at sub-district level to respond to any a small case to prevent an outbreak. Then you need to enhance your treatment capacity with human resources, basic drugs, and oxygen. The things we needed for COVID was never there with us in any PHCs or the CHCs. And now we need to capacitate it. People did not know how to handle very infective respiratory diseases. No, none of us wore gloves or masks. These were unknown to us. Hardly you would find people in any of these centers wearing an apron or being dress coded in a health system. We had all sorts of colorful dresses within the health system. Well, but now that cannot be the case anymore. So we need to change our behavior, the way we dress, the way we present ourselves and treat patients. And then we need a very different quantity of drugs, and oxygen was unknown. The amount of oxygen required by a PHC was just a tiny fraction of what is required to treat one single case of severe COVID. So our country just did not have that oxygen infrastructure. Rather, most countries did not have that. So now you need it. You need to have a lot of oxygen available. Oxygen, in sense, it's just not about the air. It is also about the infrastructure that comes with it, the accessories that comes with it, the refilling capacity, and the technical know-how of dealing with these equipments. Then you need to have a referral mechanism for severe cases. So you have this designated nodal COVID care centers. But what if the patient gets sick? Where do you send them? Then you need to send them to a district hospital or a sub-district hospital. Fair enough. But then these tertiary centers, the district or district hospitals should be prepared to handle severe cases, which would mean that they have a designated ICU left exclusively for this. And all this preparedness needs to exist even in absence of a case, or absence of an outbreak, in anticipation of an outbreak. This is going to be quite challenging for our health systems in times to come. So what are these challenges which I'm referring to? The challenges would mean that we need significant investment in preparedness at all levels. Firstly, we need additional health structures to designate them as a COVID treatment centers or a CHC. So you have to sacrifice one of your existing primary health center or a CHC at all across the country which already are in shortage and designate them as an exclusive center for COVID. This is going to be quite challenging. And I have seen in many parts of the country that they have now come up with the old fallen buildings have been refurbished. And you see a lot of what they call booth bungalows, which are just left by the government. They've all been refurbished, repainted, re-electrified, and converted into treatment centers. That's happening. The process is on. Many centers which were marked for demolition are now marked for as COVID centers. Some places are quite innovative. They have turned their old buses and a very or a different container systems into COVID treatment centers. And this health structure has to remain waiting for a COVID case, which means that in a very given remote district, it will remain empty for a whole year. So to run an empty hospital or a small empty health structure for a while. Then you need additional trained human resources for treatment and response systems. Our people really do not know how to treat COVID or handle this disease. So it requires an upskilling of ourselves, right from an ambulance driver to a guard up to a specialist doctor. They need to gain new skills and gain and practice their job differently. This is going to take enormous time. Then we need some additional drugs, oxygen, as I said, consumables exclusively for COVID management. And we see that across the country, small hospitals have now been mandated to have an oxygen plant. So, and that has actually happened rapidly in the past 6 months. The amount of oxygen plants that have come up in most of these government hospitals is phenomenal, with 1,000 liters capacity per minute. But the challenge is maintaining them. Recently, in a medical tertiary hospital, I saw that without a COVID case, the amount of oxygen that was utilized was about 100 liters per minute, considering all the operations and cesarean sections and pneumonias that they treated, about 200 patients. But the capacity of the oxygen producing machines, which have been installed by the government, are about 1,000 liters per minute, and that is needed for COVID. So that means you're going to underutilize your resources for a long time, and that comes at a huge maintenance and technical costs. So we'll have to upskill a lot of people to even handle these kinds of mechanical challenges. And during COVID outbreaks of the last first and second wave, it was not about only shortage of doctors and nurses. It was shortage of oxygen handling technicians, what we call as biomedical technicians. We did not have people to provide us adequate wiring or piping. And many of our government hospitals suffered from this, including private. In fact, our own field hospital in Fall could not manage to get a biomedical technician for 1 month, and we managed through various different jugaads. So this is the kind of shortage we had in our country and we still continue to have. And this needs a lot of work. Likewise, at a tertiary center, what we require now is to designate specific wards for COVID, which means that you have empty wards, still with all these equipments and people, but not functioning. Likewise, you need ICU beds separately, anticipating 1 or 2 odd cases that come from the field. And then you need operation theaters in higher centers, which are meant to be exclusively for COVID, or able to turn it into a COVID OT. That is, you're performing surgery on a person who's COVID positive. The surgery may be for many other reasons. So this capacity has to be increased or our tertiary centers have to gain this capacity, which is going to be challenging too. And of course, you need additional, as already mentioned, oxygen capacity at these centers, which I think is a very positive development. So these are the challenges and requirements, but what are the ground realities? I cannot speak for the entire country, but I can speak from some experience traveling in the last few months and from what I know through other sources. The first thing is that the health systems are yet to function to full capacity. Since March 2020, when they shut down the health systems, no part of the country has seen a health system come back to full life. They're still scared, they're still worried, they're still refurbishing, equipping, and people are scared to come. So we do not, it would take time before all health systems function, and then we try to reorganize them to meet these challenges. So hence our prevention methods are yet to be in place. There has not been much thought on this, how to reorganize primary and second and lower levels of healthcare. There is still a lot of disorganization in the ground. Then we still require significant investment and deployment of oxygen infrastructure of the country, although it's happened enormously. But as I said, there is still more technical work to be done on this. And we still do not have this designation of additional beds and inpatient resources at all parts, but significant, at least in South India, things are better. And we are yet to have reasonably trained human resources. All the human resources that are currently functioning are not trained in management of COVID. During these two waves, we had only some small part of the human resource participate in this emergency response, and they were given some emergency training. But then a significant number of people did not turn up to help, or they were not asked to help because of various other issues. So they remain untrained in handling or even preventing or even handling cases. And we also have a general lack of skilled human resources. We, as it is, lack nurses. We lack multi-purpose workers. We lack Anganwadi workers. Only ASHA workers are in good supply. But we lack many other. We lack doctors. So this is one ground reality which we need to confront. Do we have some time? I have another 3 slides to go.
Yes, sir. Yeah, you can carry on.
Thank you. Yeah. Now we can talk about very large challenges, which are challenges to what the country or the state or the governments face due to all these. Right? We're trying to understand challenges right from the ground up till that of the predicaments of the government. Going ahead, there's going to be a significant increase in health budgets of all states. Why? Because of all the reasons I mentioned right some time ago, from upskilling to upscaling. So that's going to cost money. And a lot of money is going to seem, a lot of resources will stay stagnant waiting for something to happen. Yeah? And then increasing skilled human resource in health cannot happen overnight. It requires a long-term vision and a long-term program. Can't get people to graduate as nurses or doctors overnight. So this remains a big challenge, and I think this is well discussed all through the two waves. Then we're going to see some periodic disruptions in health system delivery services due to outbreaks. There'll be some small outbreak in a district. The entire national programs there comes to standstill. Maybe, and this can happen repeatedly in different parts of the country. So this will affect delivery of healthcare services and achievement of health indicators. And it can decrease health-seeking behavior. This is something we're already seeing. What's happening is people are scared to come to a hospital with the threat, because there's a threat of getting COVID. So they are resorting to finding local, unsafe, unscientific solutions around them. So there is no easy fix to it. People just won't come unless they feel safe at any part, in any part of the country. And this can affect people with a lot of across diseases, including malnutrition. And there's going to be an indirect impact on all health programs and other health indicators because of these disruptions. And then you need to find money. Money has to be diverted from different health programs, and there has to be some creative utilization of resources. So that will cause a strain on different health programs. So if I were to think of this post-COVID impact on the health system, I I would say that there's already an appreciable impact. There's some evidence that the tuberculosis program, especially the diagnosis and treatment, has been significantly taken ahead. So less number of people are diagnosed and people are incompletely treated for TB. So this will have a long-term impact on our health indicators. And there's a huge risk of developing drug-resistant tuberculosis due to incomplete treatment. And that is a mess to handle. Our HIV care program also has taken a beating because funds, of course, are redirected, and human resources who are more involved in these two programs are now more involved in COVID. And neglected tropical diseases, these are unheard of. Kala Azar. We had an outbreak of scrub typhus, very uncommon. We had it in Bangalore. We had it in Uttar Pradesh, Bihar, Delhi. This was not a common thing to happen. So and then we see these post-Kala Azar syndromes coming up in central India now. These are already neglected tropical diseases, and under this kind of a health system stress, they've been further neglected, and they will definitely have some humanitarian impacts. Some of the projected impacts would be on child and adult malnutrition. We are yet to see this impact or appreciate it. We all very well know that malnutrition or nutrition status doesn't change overnight. It will take time for it to change. It will take much more time for us to appreciate, measure, realize, analyze. Over a period of time, we can see that nutrition indicators may worsen. This is a projection. I hope it turns out to be otherwise. Adult malnutrition also may increase, or because other social programs that deal with adult malnutrition, like Manrega, will is expected to receive less funding, and people may not even participate in labor due to the threat of COVID, and hence it can have some impact on their nutrition status over time. This, of course, we need to wait and watch. We would know 5 years from today what's going to happen with this. And antenatal institutional deliveries. Again, people are scared. We already see that the number of ANC visits that's required by a pregnant mother has decreased or is decreasing. And likewise, there could be a threat to institutional deliveries because the CHEs may not just be functioning. We've seen many non-functional CHEs are shut down due to COVID or repurposed to COVID wards. So there could be a decrease in institutional delivery. On the other hand, all these repurposing, recharging, relooking at things can have some positive impacts, and they are. Our immunization program is bound to get strengthened because we are pushing for COVID vaccines, vaccinations. We are using all possible methods to do it. And this has some collateral benefits to the existing immunization program. People's interest in immunization and the importance of immunization or realization of it has increased. And we expect a more increased uptake of immunization for other diseases. And enhanced secondary care infrastructure in rural and tribal areas, of course. We see that most of the small hospitals now have a government-funded oxygen generator. The power capacity, that is electricity capacity to all these small centers have increased. It's very easy to put a transformer now. To get a transformer to a hospital, it would take a year previously, running through the DC, Assistant Commissioner, and different electricity companies. But in the past year, that has not been our experience. We can get a transformer overnight because that importance has increased. So they're better electrified now. And most of our secondary centers have got new beds, they have got new masks, they have some central pipings. So the infrastructure basically has increased because of this adaptation which we spoke about. And if we were to work well, we can increase the skill of our health workers, that they are better prepared, better dressed, and better and more responsive to situations. This I also foresee that there can be increase in outreach models of care, where health and medicine need not always be delivered within four walls or in a big scary hospital. It can still be done locally. The Anganwadi model or the Balwadis, they have already shown that. we address more than nutrition there in these centers. We provide vaccinations, we provide preventive health measures. So likewise, there are many new models of outreach. This will be outreach care, including tuberculosis, which is done at home. So many of our programs, which are or medical care, which is happening in scary hospitals, can lead to an outreach model, or can be delivered through outreach models, and that has a lot of economic, socio-economic benefits. Likewise, this may push us to more for us to innovate and evolve new healthcare delivery models. This can happen by the NGOs, it can happen to the private sector, or even the government can out of box think something new and put up a different model rather than the whole old 1946 model of sub-center, primary health center, CHC, SDH, DH models. So this is something which was conceived in the early part of 20th century, and we're entering the mid part of 21st century. Probably we can have newer healthcare models. In the urban centers, we also already see digitization. We see this we see this telemedicine and all these wonderful technologies, which may not sustain or which will not be applicable to rural areas, but there is still there is room for creativity. And then it can lead to strengthening of emergency preparedness and response. Until date, all this emergency preparedness and response meant responding to floods, earthquakes, and drought. Bring in a helicopter, drop food, rush to build a bridge or evacuate people. There's hardly any medicine into it. It was all led by this particular department called as State Disaster Management Team. Now things have changed. The medical emergency there has been more appreciated, and at district levels they are including a medical response, and this not only would strengthen a response to COVID, but there's benefit that you can respond to this preparedness can respond to any other outbreak. We saw that recently in central India there was an outbreak of cholera in a very remote area. You had everybody, right from the WHO to the district, responding, and there were only 7 deaths in that particular area. Cholera usually causes hundreds of deaths, but this was that we could see the district administration flinging into action. Likewise, we had a very large outbreak of dengue in North India, even in Bangalore. Such a scale of outbreak of dengue happened 10 years ago. It is still ongoing. And the scrub typhus, as I mentioned earlier, you had systems to immediately jump on it and diagnose. You can do a big viral panel immediately. So there is collateral benefit on emergency preparedness and response. Yeah, so these are the broad impacts on post-COVID scenarios of health on health systems which I can think of. And I would like to conclude by a statement of reflection that the coming of COVID-19 pandemic is a highly significant event in human history for a lot of social reasons as well. But this pandemic is expected to reshape the way we organize and deliver healthcare in society. So I'll stop here. Thank you very much for patiently hearing me out. And I would open the floor to discussion if the chair permits. Over to the chair. Thank you.
Yes. Yes. Lakshmi?
Yeah, yes, ma'am. Thank you, sir, for the deep insight into the post-COVID scenario. You have touched upon a lot of factors, including the concerns and uncertainties of COVID-19, the role of existing health scenario, role of existing health systems, how to adapt with the situations, and even the respiratory triage challenges in the prevention of COVID in future. So I think it was a wonderful talk, sir. So I think we can have questions from the participants.
Lakshmi,
yeah, ma'am.
even if they want to, open and ask, they can.
Yes, ma'am.
Yeah.
Sir, you can see the chat box also. As per now, 2 questions came.
Okay. Do we first take the questions in the chat box before we open?
Anything, sir. Right now it is there. I think we can finish and then.
One question from Dr. Sundarvali. Have we got herd immunity? Unlikely. Although some of the 0.0 surveys do point out an increased amount of immunity in different cities, but it's unlikely that we have reached this herd immunity for two reasons. One is that we still do not know what is the level of immunity that is required to call as herd immunity. Very traditional epidemiology suggests that we need 62% of people with the antibodies, but we are not sure if there's any city that has reached. But I'm sure you can challenge me with a lot of news reports that come usually from Delhi and Mumbai, which says that we've reached 90% immunity. So these studies, I can promise you, are of very poor quality, although conducted by the government or government agencies. It does not really reflect the reality. In support of my statement is that you just go through all the herd immunity sero surveys that came after the first wave, especially from Dharavi, Mumbai, and Delhi. It looked like as though they have naturally won COVID, but these are the worst COVID outbreaks in human history. So these sero surveys, the way they have been conducted, the first sero survey conducted by ICMR was pretty good. They followed a very nice model. The second and third is quite questionable. The third and fourth, we don't know what's the study methodology. So I wouldn't go by any of these sero surveys. The next is there data from the last 2 years who were more susceptible of COVID, undernourished or overnourished? First thing, okay. Now there is no such data on nutrition. I'll tell you the reason is there are two reasons. Most of any data with COVID, forget about nutrition. Whatever comes coming from China or is coming from northwestern Europe and United States, and some from Brazil and South American countries. Anything related to COVID, and none of these people share the same context as ours. They do not suffer the amount of malnutrition we do. So therefore, there is no data on nutrition, and there's no other kind of data in India, let alone malnutrition and nutrition. So nobody has really studied it. The one other reason is that the more malnutrition is more appreciated in children who are not susceptible to COVID. So we still do not know what's happening with COVID pneumonia and in children. And the second thing is that the adult malnutrition largely exists in rural and tribal areas, and COVID only second wave has hit them. They were spared of the first wave, and the second wave data is yet to be analyzed, and I'm not sure it will ever be, and difficult to get any such data. From our limited experience, we had treating very severe and critical COVID first-hand experience in certain impoverished areas. I do think that there was a link between malnutrition and COVID deaths. But this is only my opinion or my experience, not analyzed data. Yeah. Next, so it continues. Does deficiency of vitamin D, calcium cause respiratory diseases? Oh no, I don't think so. We don't know anything about this. Are there any data from the last 2 years to support this? No, unfortunately. There is nothing learning that can happen from Indian data yet, unfortunately. Next one from Lakshmi Jitendran. As per statistical evidence, how long the pandemic is expected despite the vaccine drive? It is difficult to predict. We had hundreds of very beautiful prediction models during the first wave. All of them have been proved wrong. With some a small one or two have coincidentally been right. So the whole modeling science that we had, statistical science we had, has proved to be inadequate to model this particular pandemic. It's not because of the virus. It is because of the social behavior. None of our models or statistical science that exist factor in the social behavior of humans. And the amount of medical anthropology research that is available is far less than the amount of quantitative research that is available. So, and we're not able to factor in government responses. You have a national government putting along, your state government doing something, then you have a district doing something, you have apartment complexes doing something. So these things, all these things lead to whether increase or decrease of a wave. Yeah. So these are not able, we can't find. Now then you come up with the immunity with the vaccine drive. Again, the vaccines in real life, how they pan out, time has to tell. So we do not know. And how long this immunity exists, we do not know. So therefore, I would be hesitant to give a time. The WHO has said that 2024 is minimum, but we don't know. Yeah, it can be earlier, it can be later.
Thank you, sir.
Then Swarupa Kakni, I'm sorry. Do we require a booster dose? We don't know again. As I said, we do not know whether how long this immunity lasts, what new variants come, how the vaccine gained immunity response to this new viruses. So Western countries are thinking of a booster dose in certain specific populations, but we still don't know. But most likely we will end up with one booster dose. This is my hunch.
Okay.
Not evidence, hunch. Yeah. What was the impact on COVID on food program like midday meal, Anganwadi food distribution? Sorry, there is no name to this. Well, the impact was enormous because Anganwadis were closed, lockdowns. When they were open, there were hardly any people and supplies. So midday meal, of course, without school, there is no midday meal.
Correct.
So all these would have definitely will have impact on nutrition. As I said, it will take us some time to really realize what has happened with child and adult nutrition because of these COVID lockdowns, lack of midday meal, lack of Anganwadi food, and such. So the floor is open for research on this.
Participants, you can unmute and ask the questions.
Yeah. What would be the interval between for the booster dose? Is there anything like after some time, 1 year or 2 years, for the booster dose,
Well,
if it is necessary?
I don't think anybody knows this as yet. We're still struggling to fix the second dose time, and we're not sure whether this 3 months, 2 months really has an effect. So booster dose, it is unlikely that we will have much clarity unless we live through a period of time. So going by the previous flu virus, it used to be annual. But again, the time period does not always determine on science. It also there are other determinants. There is availability of vaccines, equity. Now, WHO is strongly saying that we will not have booster dose even in Western countries, simply because we need these vaccines to be given to other countries, like African countries, Southeast Asian countries, which have not even got a single dose. So there's also an equity dimension to this, to fix when we would require a booster dose.
Okay.
What about the vaccines for children? I mean, they are thinking about.
There are a few vaccines which have been tried on children, including a couple of them in India. At some point in time, they will come out. The problem is that it's difficult to conduct clinical trials on children. So there are large ethical issues, and the participants will be very difficult to find. And unlike many other situations in medical clinical research, the child has a right to refuse. Yeah. So parents cannot take a decision on behalf of the child in clinical research. So this adds an element of complexity. And any vaccine research needs to be tried on a large number of people. So to get recruiting large number of children is going to be challenging. So, but eventually they will come out. But difficult to give a timeline. I hear that it should be out in the early part of next year.
Because the schools have reopened.
Yes,
and
yes.
children are out now.
November 8th
True that.
onwards.
A big challenge, I feel.
Yes, susceptibility of children is the highest now than it was 2 years ago, undoubtedly. But it would take some time.
Okay.
Hi, Dr. Sorry, I was on and off in the session. I was on and off, yeah. But I had few questions already in my mind to ask you. And I think initially I was there for some time, so I learned about the third wave. So one thing is that now is it SARS-CoV-2, but are there any other types of viruses which we could see? Because there was also some kind of news that not only this coronavirus, but there can be other kinds of viruses in future. So then how the health system is looking into that actually?
Well, at this point in time, there are no other viruses known to us which are threatening to blow up like COVID-19. Although there are many other smaller outbreaks that are happening, Ebola is still continuing. Then you have many other. In India, dengue still continues to be a threat, but there are no new variants of viruses which has been appreciated elsewhere in the world. But yes, of course, there can be still new viruses. It has always remained a threat, and it continues to remain a threat. And I don't think anybody, although people do talk, there are in such webinars, forums, people talk about it. They write about it because you have so many newspapers that we need to prepare. But I don't see anybody looking into that kind of a preparation. There are many reasons for it. One is that we don't know what challenge is going to come up. It's all predictive models through computers, which will tell you that stomach virus will come or an eye virus will come. But and then we are hardly any health system is able to cope with the current one. So I'm not sure if even if people talk about preparing, we can really prepare for another pandemic.
And other one is regarding the vaccine side effects. So we had been seeing in the news and even recent reported in Hyderabad about that intestinal gangrene, which was reported. And also we see large number of heart attacks and then other organ failures. So is it related with post-COVID effects or vaccine effects, or how do we look at it? Because healthy people and vaccinated people are also having the similar, the damages.
Well, every vaccine or any drug will have a side effect, and sometimes they can be fatal due to various reasons. Every vaccine. So that's COVID vaccine is not out of this paradigm. Sorry, I think. Right, thank you. So, COVID vaccine does has its side effects, which can be sometimes fatal. But I'm not sure if it's going to happen. It is very significant. Although you do find people in large numbers, as you use the term, is because we are also administering vaccines in very huge numbers. Even a 0.01% risk of death will still be see a large number of people dying. So this is the largest amount of vaccines administered in a short period in human history. So you will definitely see large number of side effects that come by, and this is a price we pay for whatever has happened. We'll have to look at this numbers people dying versus the benefits that are coming up due to these vaccinations. And the current vaccines which we have, the various different plethora of them, the incidence of adverse events or death underweigh the large benefits that you have. So on a population level, we have to accept, there's no choice but to accept these possible mortalities and go for these large scale vaccinations. So if we don't do this, we'll have more number of people dying of COVID than the side effects of vaccinations.
Are there any more questions? Do we have questions from the participants? Or we can.
Why have children become increasingly vulnerable than earlier times?
Ma'am, but I'll
Well, because now the movement of children is more, as one of the chair mentioned, that we have more schools opening, so children are moving around, and children are more exposed to infected adults than they were before because you have more infected adults. So hence they are more vulnerable now than any time else.
Maybe if you want, I'll just click one photo.
Any more questions?
Then it is advisable to keep away children from mingling in crowds. So is it fair in opening schools, doctor?
Well, this is a very difficult question to answer, and I don't think there's any yes and no for this. I hope I'm unmuted. Yeah. It is definitely true that we should keep children away from crowds. Not only children, even adults. We should stay away from crowds. We should not crowd ourselves. So the threat of COVID is still real, undoubtedly. But opening schools, again, they would see the amount of. It's a public health decision. It's a major social decision as well. To see the risk and benefits. The problem with not opening schools from past 2 years is leading to a big. Is leading to a social issue. Children are losing out on education. This has long-term repercussions on a child individually, on a family, and even on the society. So that has further economic repercussions. So we'll have to look at it with That, as well as the risk of a child getting COVID and possibly leading to death. So, I would say that it would, if we were to have reasonable safeguards within schools, and then health systems are prepared to handle pediatric cases if there's an outbreak, then a limited opening of schools may be okay in certain places.
Okay.
But
Okay,
there's no
you have an
one-person answer to all
appreciation.
this. Yeah.
That was a very good appreciation. Thank you very much, sir. That was a very, very comprehensive presentation. Okay. So if we don't have any more questions, we will close the session. Thank you very much, sir, for that wonderful presentation of the positive impact of COVID and also the challenges we have ahead to overcome many of the challenges that is we are coming, we have to in the future, the health system. So it was a very, very elaborate presentation, and also to the point we have noted down that how we have to carry out this in the future. Thank you very much, sir. And I also thank Dr. Jyoti for connecting us with you. So in future, if we have any collaborative work that we can take your help, sir. Thank you very much. So I thank all the participants who are here for this session, and also for all the sessions which were happening from the NSI Bangalore chapter. I take this opportunity to thank all the NSI executive members, Dr. Mary Reggie, the co-convener of the chapter, then Treasurer Lakshmi Jitendran, and the executive members, Dr. Sumati Swaminathan, Dr. Jyoti, Dr. Banu Deshpande, Dr. Swarupa, and Dr. Kanabu, for taking all the troubles and being cooperatively working for the sessions, all the sessions we had. And I once again thank the members, NSI members, students, faculty, and the research scholars, the dietitians who were with us in this journey. Thank you once again. Thank you, sir, for the. Thank you.
We can take a snap, ma'am. Kindly switch on the video.
Kindly, all the executive members and also the participants, please switch on your video, please.
Students, you can also switch on the video. Yeah, ma'am. Thank you.
Yeah.
Thank you, Dr. Himanshu. On my Nutrition Society of India behalf and personal behalf also. Thank you so much. Though you were traveling and though you were in Northeast and then could not connect to us, but even then you readily accepted to deliver the talk, and in spite of your schedule also, you were able to really give us
Dr.
good
Jyoti was telling us about this. You were a very, very busy person and you have a tight schedule. Thank you for
I must apologize. I must apologize for not responding immediately.
No, not at all, sir.
But I was in very difficult circumstances, so sorry for that. I just arrived in Bangalore 2 days ago. So thanks for the questions and thanks for providing me this opportunity. I hope I made justice to your time.
Thank you, sir.
Definitely, we'll be in we'll connect with you in future also, Dr. Himanshu.
Sure. Thank you.
Okay. Thank you so much.
Wish you all best wishes. Bye.
Thank you, everyone.
Happy Diwali to all.
Happy Diwali to all. Yeah.
Thank you. Wish you all the same.
Yes. Happy Diwali to all. Thank you.
Kindly fill up the feedback form posted in the chat box. We'll be there for some more time, so you can just fill up the feedback form. ma'am.
Thank you very much, Lakshmi.
Over.
சூப்பரா பண்ணடி. இதெல்லாம் வந்து கன்க்ளூடிங் எல்லாம் ரொம்ப நல்லா பண்ண. Vote
ஓகே
of thanks.
யா
Okay.
தேங்க்யூ மேம். சரி
நல்லா
அப்போ
பண்ணாரு.
முடிச்சுக்கலாம்.
கிளியரா இருந்துச்சு, ஆடிபிளா இருந்துச்சு. His
Okay,
talk was,
fine.
no?
Yeah,
Very
it
nice.
was very
You
clear.
were
Only,
also very good.
see, only thing, no, ma'am, because of too many webinars, no, people don't know the importance. இப்போ நம்ம கூட ஒன்றுமே participate பண்ணதில்லை. அதனால தான் crowd became less. And one more thing I will tell you, you go to NSI Bangalore chapter, you can see the viewers of our video. More than 200 plus it has gone.
See?
So each video, no?
That is itself a big thing, right?
Yeah. So that is actually rating the thing, no? NSI Bangalore chapter. So even இதுக்கு join பண்ணாம later they are, as ma'am Mary ma'am told, no, they are waiting for that. So ஆராம்சே எப்போ நீங்க ஃப்ரீனா அது இது பண்ணிடலாம். Only Lakshmiya's was not that clear. Clarity was not there, ma'am. The audio நம்மளே அன்னைக்கே சொல்லியாச்சு இல்ல. பாக்கி எல்லாமே ma'am is very nice. சரி. இன்னைக்கு அவங்க இருந்தாங்க full time. She was there only.
Yeah, she was there.
சரி மேம் அப்பா சாமி சரணம் முடிச்சாச்சு. Have to get tell to get the money மேம். அதுதான் நம்மளுக்கு இப்போ no we have to send in these people no. சரி
இது அனுப்பிச்சிட்டு வாங்கிடலாம், ஒன்றும் கவலைப்படாத.
சரி
ஓகே, உன்னோடைய பில்லு கொடுங்க.
Zoom bill also. Anyway, I'm keeping it till the previous day, ma'am. We can also utilize for anything else.
Yes.
சரி நான் வந்து 4:30 கிளாஸ்க்கு போகிறேன். ஐ வாங்கிட்டேன்.
என்ன கிளாஸ்க்கா?
டயபெட்டிக்ஸ் கிளாஸ் எனக்கு அந்த காலையில் எடுக்க முடியல பிகாஸ் ஐ வாஸ் கேம் டு சைன் அண்ட் ஆல்.
சரி.
சரி
சரி, and you left.
சரி சரி பை.
Okay.